Welcome back. It's Brilliant East. For the previous video, get to my channel and download. This is internal medicine video number 2. Question number 11. Mr. Cannon, a 73-year-old gentleman, presents to you with progressive shortness of breath. He can walk 10 yards before stopping to catch his breath, and he is unable to lie flat. He sleeps upright in the armchair and has stopped sleeping in the bed over the last 3 months. He has now hypertension and has 2 previous myocardial infarction. On examination, his apex breath is displaced to the 7th intercostal space, that is indicating cardiomyopathy, in the left axillary, mid-axillary line, and there are cryptation in the 2 lung bases. His jugular venous pressure is raised at 5 cm and there is bilateral leg edema. Laboratory investigation: troponin less than 20 nanogram per ml, beta natriuretic peptide 14,000 nanogram per ml. The normal range is less than 200. Chest X-ray showing cardiomegaly and increased alveolar shadowing in the peripheral areas. ECG QRS 110 ms. Large volume complexes in the chest lead. Which intervention is proven to reduce mortality in this case? The answer is D, Lamipray. It seems Lamipray are good drugs. ACE inhibitors are good drugs for myocardial infarction and hypertension. Question number 12. You are an intern doctor at regional hospital and you review a 67-year-old man who has type 2 diabetes. His glycemic control is reasonable with metformin therapy. The latest HbA1c is 54 millimoles per mole, 7.1%. The normal is less than 6.5%. No. A few weeks ago, he was noted to have a clinic blood pressure reading of 152/90. Hypertension. A 24 blood pressure monitor was requested. The report shows his average blood pressure was 142/88 mm of mercury. What is the most appropriate course of action? The answer is B. Start ACE inhibitor. It seems that ACE inhibitors are good in diabetic patients. They are the best medication in diabetes. Question number 13. A 56-year-old male patient who, with no history of ischemic heart disease, had an ST elevation myocardial infarction 20 days ago. He was started on aspirin, atorvastatin, bisoprolol, and naltrexone as an inpatient. He had been discharged to your care in the cardiology outpatient department. He presented for review 1 month later saying he remains breathless on minimal exertion, walking 15 meters, with no chest pain. There is no evidence of pulmonary edema on examination. A recent echocardiogram shows a left ventricular ejection fraction of 40%. His beta natriuretic peptide level is 4,636 pg per ml. Normal, usually less than 100. What would be the most appropriate to add to his oral therapy? The answer is B. Spironolactone, potassium sparing diuretic is the best to add. And if you compare with other choice, that's the best. Question number 14. A 30-year-old homeless lady has cough, sputum, and fever for the past few months. She complains of night sweats and has lost 13 kg in the past 6 months. A chest X-ray was performed which showed apical movement with infiltrate and cavitation in the upper lobe of the right lung. What is the next single most appropriate test to perform? The answer is A. Acid-fast bacillus smear, because you see there is night sweat and other features of TB. Question number 15. A 23-year-old intravenous drug user presents to you with bilateral growing abscess. After drainage of the abscess, he is started on intravenous flucloxacin and gentamicin. 12 hours later, he complained of diplopia, which deteriorated and also developed dysphagia and muscle weakness, and needed ventilatory support. His past medical history is significance of myasthenia gravis. What is the diagnosis? The answer is A. Aminoglycoside-induced neuromuscular blockage. It's just that when a person is started with flucloxacin tend to worsen myasthenia gravis whenever the patient had previous myasthenia gravis. Question number 16. Mr. Mkunde is 65-year-old man referred to a respiratory clinic by his general practitioner. The patient gives a 3-month history of productive cough and steady weight loss of 10 kg. His sputum had initially been yellow, but over the past week he has noticed streaks of blood. He also complains of sweat at night, and sometimes he had to change his bedclothes. He has a long-standing history of bronchial asthma that has required admission to hospital on several occasions. On two occasions, he has been admitted in respiratory distress and has required intubation and ventilation. His current therapy includes salbutamol and beclomethasone inhaler and prednisone 5 mg once daily. He has taken for several years. He also has a home nebulizer which he uses as required. His chest X-ray in clinic shows right apical consolidation. The last chest radiograph, taken 6 months previous on admission to hospital, had been normal. A sputum sample proves to be positive for acid-fast bacillus. A presumptive diagnosis of pulmonary tuberculosis is made, and he is started on antitubercular therapy. 5 days later, he presents to casualty with breathlessness and wheezes. On examination, he is febrile, widespread expiratory wheezes on a head throughout his chest. His peak expiratory flow rate is measured at 110 liters per minute, has greatly reduced. His chest X-ray does not show any significant change from the last film taken in chest X-ray clinic. Which of the following option would be the most appropriate step in his management? The answer is C. Continue antitubercular therapy and increase steroid dose, because this is TB. You need to treat TB. Question number 17. A 35-year-old woman presents to the OPD complaining of chronic cramp, abdominal pain, and intermittent constipation and diarrhea, but no weight loss or gastrointestinal bleeding. Abdominal pain is usually relieved by defecation. Colonoscopy and upper endoscopy with biopsy are normal, and stool cultures are negative. Which of the following is the most likely diagnosis? The answer is B. Irritable bowel syndrome, because the colonoscopy and upper endoscopy and biopsy both are normal. That is just irritable bowel. If it would be Crohn's disease like that, you could say the gallbladder stone appearance, but The endoscope and the colonoscope are normal, so that is irritable bowel syndrome, and the other choices doesn't fit with the question. Question number 18. A 60-year-old man was diagnosed last year with adenocarcinoma of the lung, and a 4 cm mass lesion was treated with a right lower lobectomy. He now has an abdominal CT scan that reveals scarred hepatic masses lesion and hilar lymphadenopathy. For several weeks, he has had increasing malaise. A urinary cyst revealed marked proteinuria, and a 24-hour urine protein correction is 2.7 grams per 24 hours. His serum urea is 30 millimole per liter. The average range is 2.5 to 7.5, with creatinine of 450 micromole per liter has increased. Normal range 60 to 110. A renal biopsy is performed, and there is focal deposition of immunoglobulin G and C3 protein with a granular pattern. He is most likely to have which of the following condition? The answer is B. Membranous glomerulonephritis. It somehow relates to Goodpasture syndrome, but membranous glomerulonephritis is the protein the immunoglobulin get deposited on the podocytes, and while in Goodpasture syndrome usually it's due to damage of the podocytes. Question number 19. You have been called to attend a 25-year-old lady with non-systemic lupus erythematosus presenting with the nephrotic syndrome. You perform a renal biopsy, and this confirms diffuse proliferative glomerulonephritis, called Hess organization class 4. Which of the following treatment regime would you advise? The answer is D. Prednisolone and intravenous cyclophosphamide. This is a common treatment in kidney issue nephrotic syndromes. Question number 20. A 48-year-old man is referred to your clinic by his primary care provider after recently laboratory study showed glomerular filtration rate calculated using the MDRD study equation of 55 ml per minute per 1.7 cm². Medical history include diagnosis of type 2 diabetes mellitus 10 years ago and diagnosis of hypertension 5 years ago. Current medication include Calvedero 12.5 mg twice a day, lisinopril ACE inhibitor 20 mg daily, and Glipizide 5 mg daily as antibiotic medication. Recent laboratory study of serum show hemoglobin A1C of 8% has increased, and potassium level of 4.5 ml equivalent per liter. That's normal. Body mass index is 24.2 kg per meter square, normal. Pulse rate is 64 beats per minute reduced, and blood pressure is 124/64, normal. Physical examination shows no abnormalities. To prevent further decrease in this patient glomerular filtration rate, which of the following changes to his drug regime is most appropriate? The answer is B. Increase the dosage of GRIPS to 10 mg twice a day. It's just that in diabetic patients, when you do well in controlling glucose, usually you reduce the glomerular filtration, because when glucose is in high concentration inside the blood, it tends to be filtered. It needs to be filtered by the kidney. So By controlling glucose, you reduce the glomerular filtration rate. That's why we give glucose. Subscribe, like, hit the bell sign and share our video. It's been Godfrey Oscar. You're warmly welcome.